Hello, everyone. Welcome to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or just whenever curiosity calls. I'm Rawad Turko, your host for today's episode, and I'm joined by Mohammed Alfuwais.
Hello, everyone. Today we have some interesting cases to discuss.
Let's get started.
Meet our first patient, Amy. She's a 55-year-old woman who arrives at the emergency department with severe right upper quadrant pain that started 12 hours ago. She describes the pain as constant, intense, and radiating to her right shoulder. She also reports nausea and vomiting, along with a fever that developed a few hours after the pain begun.
Okay, so given the combination of right upper quadrant pain, fever, and nausea, our top differentials include cholecystitis and cholangitis.
Yes, we're going to break down each one of them, but let's start with cholecystitis. Cholecystitis can present in different forms. So we have acute calculus cholecystitis, acute acalculous cholecystitis, and chronic cholecystitis.
Okay, I think let's start with acute calculus cholecystitis. Calculus, I think, means that we have stones, right?
Yep, exactly. Acute calculus cholecystitis happens when a gallstone blocks the cystic duct, preventing bile from draining. The pain typically happens after a meal because the gallbladder contracts. Basically, when you eat, your body makes cholecystokinin, which stimulates the contraction of the gallbladder. But in this case, the bile duct is obstructed. So the gallbladder squeezes against the pressure of this blockage, and that causes severe pain after eating.
Okay, and wouldn't this obstruction cause stasis of the bile?
Yeah, it would. And this stasis irritates the gallbladder lining, which stimulates the mucosal layer of the gallbladder to produce more mucus. But unfortunately, this is ineffective because the bile is still stagnant there. So over time, you get bacterial overgrowth in the gallbladder, leading to inflammation and infection.
Which bacteria specifically are we thinking of?
You would most commonly see E. coli, Klebsiella, and Enterococci.
So, at this stage, the gallbladder wall has become inflamed and swollen. And what happens if this infection worsens?
If it keeps going, the bacteria may invade the gallbladder wall and cause peritonitis, and presents with rebound tenderness on the physical exam.
Okay, and what usually happens to the gallstone that was blocking the duct?
So there are several possible outcomes. The seemingly lucky outcome would be if the stone fell back into the gallbladder lumen. So basically, you wouldn't have blockage anymore and the inflammation will subside.
But the blockage can get worse, right?
Yeah, if the stone that was stuck in the cystic duct moved further down the biliary tree, it could get into the common bile duct and obstruct it. Or another possibility is that the stone may be impacted and compress the cystic artery.
And the cystic artery supplies the gallbladder, so if it's compressed, you would get ischemia?
Yes, you would get something called gangrenous necrosis of the gallbladder wall, which would weaken the gallbladder wall and could unfortunately lead to perforation.
I think that covers acute calculus cholecystitis pretty well. You said something about acute acalculous cholecystitis. I'm guessing it doesn't involve a stone?
You guessed it right. Unlike calculus cholecystitis, this type of cholecystitis occurs in the absence of gallstones, and it's typically seen in critically ill patients.
What type of critically ill patients?
It's usually seen postoperatively in patients who have had major, non-biliary surgery. It can also be seen in patients with severe trauma or burns, multi-organ failure, patients in a postpartum state, or even those who have had prolonged total parenteral nutrition, or TPN for short.
What exactly predisposes these patients to cholecystitis if there's no gallstone involved?
The main thing that happens in the critically ill patients is ischemia to the gallbladder. So basically, that could cause damage by bacterial contamination or even by inflammation or edema of the wall.
Oh, okay. So that would cause acute cholecystitis that's acalculous. How about bile stasis? Can you get it without a stone obstructing the ducts?
Actually, yes, you can. Bile can sometimes turn into some sort of bile sludge that could clog up the bile ducts. So, for example, dehydration can make the bile so concentrated that it becomes thick and viscous like a sludge. When this sludge accumulates, it would irritate the gallbladder, leading to cholecystitis.
Is that the same thing that happens to patients on total parenteral nutrition?
It's kind of close, but not exactly the same. The main idea in patients on prolonged TPN is that they have stasis of the bile in the gallbladder. Do you remember when we said that cholecystokinin makes the gallbladder contract?
Yeah, and we said that it's released when we eat.
Exactly. So it's released when food goes through the GI tract. What do you think will happen when someone is on TPN?
Oh, so since TPN is given through IV, you don't have food going through the GI tract.
Yeah, and so there's nothing to actually stimulate the release of cholecystokinin. And basically, nothing makes the gallbladder contract, so bile just kind of stays there.
All right, so bile stasis eventually irritates the gallbladder, leading to cholecystitis.
You got it.
All right, Fuis. I think that should be good enough for acute cholecystitis. Should we now move on to chronic cholecystitis?
Let's do it. So, chronic cholecystitis develops over time, obviously because it's chronic. This happens when you have recurrent inflammation and chronic injury to the gallbladder wall, eventually leading to fibrosis.
Do you always have to have a stone lodged in the duct for this to happen?
Not necessarily. Chronic inflammation may also occur due to persistent irritation from multiple small stones within the gallbladder lumen. Now, over time, the mucosal layer flattens and the gallbladder wall thickens with fibrous tissue.
So the patients with acute cholecystitis, where the stone went back into the gallbladder, weren't all lucky then, huh?
Yeah, unfortunately not.
So this fibrosis and chronic cholecystitis would make it hard for the gallbladder to contract and release bile. Is that correct?
Yeah, these patients actually have digestive issues because when they eat, their gallbladder cannot empty properly. So, like you said, the wall is essentially fixed in place because of all the fibrosis and scarring and can't contract like it normally would.
What happens if the chronic cholecystitis stays for a very long time?
In some cases, the gallbladder would turn into what we call a porcelain gallbladder. Basically, it develops dystrophic calcification, where calcium seeps into the wall, making it very hard like porcelain.
Right, and since their calcification, I'm guessing this can be picked up on plain x-ray?
Yep, and that's actually how it's usually picked up.
Okay, let's go back to our patient Amy. The other possible cause of her symptoms was cholangitis. Let's dig some more into that.
So, cholangitis is inflammation of the bile and the bile ducts. This most commonly happens when bacteria ascends up from the intestines through the ampulla vata and into the common bile duct. So we can call it ascending cholangitis or acute cholangitis.
Now, why would someone develop ascending cholangitis?
Normally, when bile flows through the ducts, it flushes bacteria out of the biliary tree. However, if there's a blockage, bacteria can travel upward into the bile ducts without being flushed down. So this can cause an infection.
So it can happen if someone has gallstones in the bile ducts?
Yes, that's one possible cause. The blockage can also be due to strictures from inflammation or fibrosis, or due to tumors in the bile duct, or the head of the pancreas.
Head of the pancreas?
Yeah, remember that the bile duct goes through the head of the pancreas?
Oh, yeah, that's right. I was wondering, can ascending cholangitis happen in the bile ducts that are inside the liver?
Yeah, cholangitis can occur anywhere in the biliary tree, either inside or outside the liver.
And what would happen to the liver in that case?
When there is cholangitis within the liver, you may see retrograde bile flow into the portal triads. This can destroy the cells and lead to biliary cirrhosis, which we'll dig into more in a bit.
All right, so there's bacteria going up through the biliary tree from the intestine. What are the most common bacteria that we should suspect in this case?
Similar to cholecystitis, the most common are E. coli, Klebsiella, and Enterococci.
And what is the typical presentation of a patient with cholangitis?
So ascending cholangitis has a classical presentation called Charcot's Triad, where you would see fever, jaundice, and right upper quadrant pain.
Does it present the same way in even more severe cases?
If the infection worsens and the patient develops sepsis, you'll see another classic presentation called Reynolds Pentad. This is basically Charcot's Triad plus hypotension and confusion. These additional signs indicate septic shock, so it's become an emergency now.
Okay, so Charcot's Triad with fever, jaundice, and right upper quadrant pain. Then Reynolds Pentad, where you add hypotension and confusion.
Exactly.
Okay, great. Let's take a quick practice question to make sure we're on track. A patient presents with fever, jaundice, and right upper quadrant pain. What is the most likely diagnosis? The answer is ascending cholangitis.
Now let's move on to our next case. Now imagine a 40-year-old woman who presents with fatigue and pruritus. Over time, she develops xanthomas, steatorrhea, and osteomalacia due to malabsorption. As the disease progresses, signs of end-stage liver disease begin to appear.
So there's pruritus, xanthomas, and malabsorption. Is this primary biliary cirrhosis?
Exactly, it is. Primary biliary cirrhosis is a chronic progressive cholestatic disease of the liver. The exact cause is unknown, but it's most likely autoimmune.
Can you talk to me about the pathogenesis?
It starts with autoimmune destructions of small to intermediate bile ducts due to an unknown trigger. This leads to chronic cholestasis, where bile accumulates and damages liver cells. The The toxic substances in bile, like bile salts and copper, are retained within the liver and flow into the hepatic parenchyma, causing further hepatocyte and bile duct injury. Eventually, the liver undergoes fibrosis and progresses to cirrhosis, leading to liver failure.
So it starts with destruction of bile ducts and accumulation of bile in the liver, leading to fibrosis.
Exactly, and PBC can get pretty severe, even leading to death.
So talk to me about what the major causes of death are in this case.
Patients may die from liver failure itself or from massive variceal hemorrhage due to portal hypertension. They could also die due to infections from liver dysfunction and immune compromise.
Got it. So liver failure, variceal hemorrhage, and infections are the main causes of mortality in primary biliary cirrhosis. If you suspect that a patient has primary biliary cirrhosis, how do you go about diagnosing it?
So some non-specific lab findings would include a significant elevation in alkaline phosphatase, gamma GTP, and IgM levels. You might also see elevated AST and ALT, but the hallmark of PBC that you should really look out for is the presence of antimitochondrial antibodies, or AMA. These antibodies are present in most patients, and from their name, they target enzymes in the mitochondria.
So finding AMA positivity is a strong clue for diagnosis?
Exactly, AMA is highly specific for PBC.
And what would you see on biopsy in this disease?
At the microscopic level, you would see lymphocyte and plasma cell infiltration of the interlobular bile ducts, which makes sense because it's autoimmune. This inflammatory infiltrate can sometimes form non-caseating granulomas.
There would also be fibrosis, right? Because the name of the disease has the word cirrhosis in it.
Yes, exactly. You would see something called bridging fibrosis, which would lead to cirrhosis. And because of the cholestasis, you might also see progressive secondary hepatic damage.
Okay, thank you, Alfuwais. So that was primary biliary cirrhosis. I'm assuming there's a secondary?
Yeah, there is. Secondary biliary cirrhosis, or SBC, occurs due to prolonged obstruction of the extrahepatic biliary tree. This leads to cholestasis, secondary inflammation, and eventually cirrhosis of the liver.
Prolonged obstruction of the extrahepatic biliary tree. I'm assuming this is obstruction by gallstones?
That can be the cause, but there are also several other etiologies, and they may actually differ between adults and children. In adults, the most common cause is actually extrahepatic cholelithiasis, or specifically gallstones in the common bile duct, like you just said. But it can also be due to malignancies of the biliary tree or the head of the pancreas, causing obstruction.
And what about SBC in children?
Children can get it from biliary atresia, cystic fibrosis, choledochal cysts, or the congenital paucity of bile duct syndrome.
So the main idea is obstruction leading to cirrhosis.
Pretty much.
And how does it lead to cirrhosis? What exactly happens?
With the prolonged obstruction of bile outflow, obviously bile would accumulate. This triggers inflammation and reactive bile duct proliferation. Over time, there is periportal fibrosis, which progresses to bridging fibrosis and eventually encircles islands of liver tissue and leads to cirrhosis.
All right, so there is inflammation, and then bile duct proliferation, and then fibrosis, and eventually cirrhosis. And that should correlate with what you see on biopsy, right?
Yeah, you would see that the liver is divided into a jigsaw-like pattern by these coarse fibrous septa. There would be dilated bile ducts filled with bile embedded within these septa. You can also see extensive proliferation of smaller bile ductules with surrounding edema. And finally, because of the prolonged obstruction, you might see bile lakes, which are basically pools of retained bile.
Okay, so fibrous septa with dilated bile ducts, proliferation of ductules, and bile lakes. What about the gross appearance of the liver in SBC?
The liver appears yellow-greenish because of the retained bile. And if you cut it, you will find that it has a hard, finely granular surface, which is a characteristic feature of cirrhosis.
That makes sense. Let's go for a practice question now. Which antibody is highly specific for primary biliary cirrhosis? And the answer is anti-mitochondrial antibody, or AMA. Our next disease is primary sclerosing cholangitis. Tell us more about it, Alfuwais.
All right, primary sclerosing cholangitis is characterized by inflammation and obliterative fibrosis of both intrahepatic and extrahepatic bile ducts.
I've also heard that it's associated with IBD, or inflammatory bowel disease.
Yeah, that's true. Primary sclerosing cholangitis is strongly associated with ulcerative colitis, to be specific, and most cases occur in men between the ages of 30 to 50 years.
Okay, so we're back to focusing on the bile ducts again, and I'm guessing there's fibrosis because the name has the word sclerosing in it. But what exactly happens in this disease?
The key pathologic feature here is concentric periductal fibrosis, also known as onion skin fibrosis. Think of the fibrosis as forming circles around the bile ducts, which progressively obliterates these ducts. You also have narrowing of the ducts at certain parts and dilation at the unaffected segments, creating a beaded bile duct appearance on MRCP. What happens here is that the parts of the bile duct that are affected will get narrow, while the parts that are not affected will look dilated.
So it's like a string of pearls kind of appearance, and this narrowing would restrict the flow of bile.
Exactly, which is why there would be cholestasis, leading to bile retention and liver damage. As this fibrosis extends, you eventually get biliary cirrhosis. Then over time, there is progressive atrophy of the bile duct epithelium, leading to complete bile duct destruction.
So essentially what I'm hearing is that primary sclerosing cholangitis causes chronic bile duct inflammation and scarring, which ultimately results in liver dysfunction.
Exactly.
And how do these patients present?
They can be either asymptomatic, where the disease is found incidentally, with persistently elevated serum alkaline phosphatase, or they can be symptomatic, where they present with chronic liver disease symptoms.
All right, Alfuwais, let's quickly recap everything we talked about today.
First, we started with cholecystitis and cholangitis. Cholecystitis is gallbladder inflammation due to gallstone obstruction or ischemia. It can be acute, calculus or acalculous, or it can be chronic, leading to fibrosis and dysfunction. Cholangitis is a bile duct infection, often caused by gallstones in the common bile duct. The classic signs of cholangitis are Charcot's Triad of fever, jaundice, and right upper quadrant pain. In more severe cases with sepsis, these patients have Reynolds Pentad, which adds hypotension and confusion to Charcot's Triad.
After that, we talked about primary biliary cirrhosis, which is an autoimmune bile duct disease causing cholestasis, pruritus, and cirrhosis. Remember the anti-mitochondrial antibodies, AMAs, and the elevated alkaline phosphatase in primary biliary cirrhosis. Then we talked about the other type, which is secondary biliary cirrhosis, where we have chronic bile duct obstruction from gallstones, tumors, or strictures causing progressive fibrosis and liver damage.
Then we explained primary sclerosing cholangitis, which is associated with inflammatory bowel disease, specifically ulcerative colitis. Don't forget that it causes concentric periductal fibrosis, which creates an onion skin appearance on histology.
And that's a wrap. In today's episode of PodBites, we covered some fascinating cases, breaking down key biliary disorders. Hopefully, you've gained some valuable insights into how these conditions present and how we diagnose them. Thank you for joining us, Alfuwais.
Thank you for having me, Rawad, and thank you to everyone listening. Don't forget to follow us and leave a review so we can continue to improve.
And as always, stay safe, stay informed, and we'll catch you in the next episode of PodBites.